My name is Mark Hennon. I'm a thoracic surgeon at Roswell Park Comprehensive Cancer Center. Today I'm going to be talking about sublobar resection for early stage non-small cell lung cancer. For many decades, the standard treatment for lung cancer was to remove the entire lobe of the lung that had the lung cancer in it. But recent data that has come out in the past couple of years has demonstrated equal long-term survival for patients that undergo sublobar resection when a tumor is small enough and lymph nodes are confirmed to be negative. Sublobar resection is when something less than the entire lobe is removed to treat the lung cancer. A patient is a good candidate for a sublobar resection if they have a small tumor that is under 2 centimeters in size, confirmation that there is no lymph node involvement with the cancer, meaning that the patient essentially has stage 1 disease, and then has a nodule in a location that is amenable, typically on the periphery of the lung or in a defined segmental anatomical area of the lung that allows for adequate surgical margins to remove it. The previous standard of care for all stages of lung cancer when talking about surgical resection for cure typically involved lobectomy, where you remove the lobe of the lung that has the cancer in it. We have 5 lobes that we're born with. There's 2 on the left and 3 on the right. And depending on which lobe is removed, it can be up to as much as half of a patient's lung volume on that side. The benefits of a sublobar resection primarily involve the preserved lung capacity that patient stands to benefit from if you can remove less of the lung. Many of our patients that are diagnosed with lung cancer do have comorbidities from a respiratory standpoint and are coming in with limited lung capacity to begin with. Being able to preserve as much lung capacity as possible potentially helps the patient have a better short-term outcome in terms of the perioperative period, as well as a long-term outcome in terms of long-term breathing symptoms and hopefully minimizing or avoiding them. The sublobar resections are sometimes more complicated technically than proceeding with a lobectomy, and our reliability with completing lung resections through minimally invasive approaches, whether it be video-assisted thoracic surgery or robotic-assisted thoracic surgery, exceeds 95% for operations such as this. With lung cancer screening, nodules are being identified at smaller and smaller sizes, and decisions regarding how best to approach them may not be immediately clear. One of the things that separates Roswell Park maybe from other institutions is our true multidisciplinary approach. We have a dedicated lung nodule tumor board comprised of a thoracic surgeon, a radiologist dedicated to thoracic imaging, as well as our lung cancer screening providers that can review on a holistic approach the likely risk of a nodule and what the best approach to diagnosing it and treating it may be. In addition to that, our multidisciplinary tumor boards for patients with small lung nodules that may be high risk for surgery help in terms of decision making of who benefits from surgery with something as such as a sublobar resection, or even considering non-operative management. It's important to refer for an evaluation because a sublobar approach may be a more definitive diagnostic as well as therapeutic approach than, say, a pathway with a potential needle biopsy, or maybe a needle biopsy might not be feasible. It's not always clear who stands, who is an appropriate candidate or who stands to benefit. By referring to Roswell Park, they can be evaluated for a lung-sparing approach.